Welcome back. I want to thank you for your patience as we traverse the virtual universe of new meetings. It is my extreme pleasure to introduce our next panel, which will be directed by Michael Moore. Mike is the Rhea Spence DeVault Professor of Otolaryngology, Head and Neck Surgery at the University of Indiana School of Medicine. He's also the Chief of the Division of Head and Neck Surgery. Mike serves as the Chair of the Cancer Prevention Service of the AHNS and has done exemplary work in this role over the last 3 years since this service line was initiated. And we really look forward to the thoughts of this panel as they discuss the effects of COVID on multidisciplinary care. Michael, thank you.
Dr. Deshler, thank you very much. Thank you to Dr. Nance and Dr. Nathan and the rest of the organizing team as well. And thanks to the AHNS staff and all the work in helping us navigate this virtual session here. So really been an informative morning. And this session obviously will focus on multidisciplinary care and how we've had to evolve and adjust our standard practices in a way that still allows us to care for our patients well. And so just some of the learning objectives we're hoping to accomplish will be to identify some of the COVID-related factors that could impact multidisciplinary head and neck cancer care, and recognize the changes that in treatment strategies that have occurred over the course of the pandemic and how we're hopefully heading back towards our more standard approach. And then to be able to distinguish who really would take priority when you're really triaging patients with more aggressive disease, and how best to navigate that in the context of limited resources within our health system. And so I'm really pleased and excited to be joined by some friends and colleagues from around the country and around North America. My co-panelists include Dr. Tony Eskander up at he's an assistant professor up at the University of Toronto. Harry Quon is a radiation oncologist and associate professor and a co-director of the Johns Hopkins Head and Neck Cancer Institute. And Tina Sacco is an associate professor and is a medical oncologist out of the UCSD Cancer Center and serves as a medical director of infusion services and a leader of the head and neck cancer team there. Lisa Evangelista is a director of speech language pathology at UC Davis. Kelly Malloy is a fellowship director and associate professor and the associate chief clinical officer of surgical and rehab services at the University of Michigan. So thank you all for joining us. These are our disclosures that are just listed here, none of which are relevant to this session. And so as you could tell from the rest of the morning, obviously the landscape of COVID has been ever changing, and it really depends a lot on where you are. This is just a plot of our local infections here in Indiana, but this is dramatically different from many other sites. And as was mentioned earlier, many places are actually experiencing this third wave as well. This has had a big impact, obviously, on many aspects of cancer care. And this session is meant to be more of a case-based discussion to really tease out some of the nuance of how different teams and different disciplines are adapting to the challenges that COVID has brought to our ability to care for patients. And so this is just a trend at our cancer center, looking at how in 2020, the volumes changed. This is a new cancer center, so the numbers are a little different than some, but as you would see, in the upper left, this is the overall clinic patients served, and there was a significant decline around the time that the pandemic started. And on the bottom left, that would be the radiation oncology volume. And so the clinic visits very quickly would result in a drop off of many surgical cases and the patients initially assessed. There would usually be a bit of a lag for decline in radiation oncology, mainly because many patients would be receiving adjuvant therapy and that was delayed. Whereas many of the medical oncology treatments really remain steady and actually slowly have continued to go up. And again, these trends are a little bit different in our facility as it's a relatively young facility, but I think these would mirror much of what's been seen around the world and around, especially the United States. And so many of the considerations that we've had to take into account when we're trying to navigate how do we care for these patients are, one, obviously the risk of infection to patients and their caregivers, the valuable healthcare team members and trying to minimize their exposure, what availability do we have as health systems to care not only for these patients, but also to care for other disease entities not affected by them, and how do we protect our other patients from getting infected? And then obviously playing into all that are our supply of PPE, health system capacity, and thing that really will be covered a bit more in the afternoon, how has this impacted education within the medical field? And so some institutions have been affected more than others, and a lot of it depends on the areas hit hardest by the pandemic, but also the way that the healthcare is provided in that region. So one example is down at MD Anderson, which is a world-class cancer center, obviously in North America in Houston. They saw a sharp decrease in their outpatient visits, almost 50%, and a significant drop-off in their surgical caseload in 2020 compared to 2019. Obviously, this is a referral center receiving patients from all over the country, if not the world. And so when travel restrictions were put in place, it was going to have a significant impact on those going to this institution for care. Similarly, this is all highlighted also by the fact that cancer patients do worse when they get COVID. So they're going to have a much higher risk of requiring mechanical ventilation and an increased risk of death. All those things we have to take into account when we're treating these patients with different types of treatments. This was a study by Dr. Bhattacharjee, as well as the team at Tata Memorial, that was essentially a multi-state model of looking at patients with advanced oral cancer. And this really highlights what we all worry about. So patients with advanced oral cancer, at least in their model, if they were taken through treatment and successfully completed treatment without getting infected with COVID, they did the best. Whereas if they started treatment but got infected by COVID, they actually did the worst. And those who weren't treated at all were somewhat in the middle. So in reality, if you could reliably care for patients in a way that kept them protected and not getting infected, that was the best outcome. But if you couldn't, then in reality, you may be best served in trying to delay their care. And so as a part of this, and we'll try and highlight some of these nuances during the course of our session, and many of these have been brought up earlier this morning, you have to take this into consideration with regard to the outpatient evaluation, not just the evaluation of the patient, but any perioperative or pre-treatment counseling and the limitations in visitor restrictions. And now that may impact the ability to communicate well with all those involved in the decision-making. The multidisciplinary collaboration, as many centers are, almost all of us are doing virtual tumor boards at this stage in the game, and the impact that may have on patients. And then the approach to care. So whether you're thinking about access to care, so surgical care in many areas has been significantly limited, especially during the height of the pandemic, where we really had to prioritize and triage what was most urgent. And then non-surgical care. So those receiving either radiation therapy, chemotherapy, and the impact that these different treatments may have on both the immune system and the risk of severe COVID, but also the ability to get patients vaccinated. And then as with most institutions, certainly ours had the clinical trial program shut down for an extended period of time, except for the most urgent ones or those directly related to the COVID pandemic. And I think one thing that we won't really have a lot of time to touch on here, but maybe mention later on in the sessions, is the impact on survivors and the ability to not only surveil them, but also to manage their long-term treatment-related side effects. And so this is a publication by Dr. Patoff and Sunwoo that really looked at to provide a framework for how do we prioritize those receiving head and neck surgery during the pandemic. And this is published in the special COVID issue of Head and Neck. And they really looked at what was the most urgent disease. So those that were the P16 negative, especially those causing airway compromise, those with very advanced or recurrent disease, or those that were rapidly progressive, really were the ones that delay, as was mentioned earlier, delay that 4 to 6 weeks would really have a major impact on their disease outcome. It was typically recommended to push forward, whereas those where it was either a low grade histopathology or benign, usually you would want to delay that unless it was causing some more life-threatening issue just related to the size of the lesion or others. And so, this is meant to be a case-based discussion. And so we have a few cases we're going to go through, and intermixed within that, we're hoping to get some audience feedback from some audience responses. And so Dr. Kelly Malloy at University of Michigan is going to present our first case, and we'll have some discussion. Because there's a bit of a delay at the time of the audience response, we'll continue some of the discussion as you're entering your answers, and then come back to the responses once they come in. So Kelly, if you want to start with the first case.
All right, thanks, Mike, and thanks for having me on this panel. I don't know if you saw my message. I'm going to present from my notes, but I can't see your slides, so it'll be kind of fun.
Fair enough. I will,
beautifully. Yeah. So our first case is of a 66-year-old gentleman presenting to your clinic with 2 months of progressive right-sided ear pain and difficulty swallowing. When you see him in the clinic, he also presents with hoarseness, and on further inquiry, that too has been slowly progressive over the last few weeks. Doesn't have any airway symptoms. There's no stridor on presentation, but on the clinical exam, you do palpate some right-sided mobile adenopathy, and a fiber optic evaluation is performed. Have we caught up, Mike?
There you go. So you got the fiber
Beautiful.
optic image now.
Gorgeous. So on fiber optic exam, you can see that the rest of the intraoral exam was normal prior to this, but you can see an ulcerative lesion of the right piriform sinus. It's obliterating that piriform sinus and really quite obvious. And then you're able to follow up with some imaging, CT images. And this confirms a large ulcerative lesion of the right piriform sinus. And the other image demonstrates the extralaryngeal spread, the erosion of the thyroid cartilage. And so the assessment is that we have a clinically staged T4A, N2B, M0, squamous cell carcinoma, well, likely squamous cell carcinoma, right? He's sitting in your clinic. And this is, here you are. It's probably the beginning of the pandemic. Your OR schedules are rapidly shutting down. This might be the last clinic visit or official clinic that you've had in the pre-COVID era, and how do we proceed in that moment, and how has that changed over time? So Mike, take it away.
Yeah, well, Kelly, I think it's a great point. I think a couple questions here. So as you mentioned, obviously, pre-pandemic, we would be taking this patient to the OR typically to get a tissue diagnosis and a formal exam under anesthesia. Have you changed your practice either during the height of the pandemic or where we are now as far as that initial workup? Are you biopsying more of the nodal disease if possible and avoiding the endoscopy, or are you just doing your normal approach to things?
Yeah, it's a great question. And when I reflect on how we had to adjust things last year, there are a couple of things that come to mind that characterize that time. One was that, I think we all experienced varying, each institution was different, but the precipitous shutdown of surgical activity and what that looked like in different individuals, the OR access was limited. And so to move these patients along rapidly, a couple of things had to happen. One, as much as you could get done in that clinic visit as possible was really critical. So yes, we did a lot of biopsying of neck nodes, confirming, presence of disease. And we also shifted into a lot of virtual care, but also virtual collaborations. We've all been doing our tumor boards virtually, but when I think about this period of time, it was like tumor boards on steroids. We had to have conversations where the surgeons were getting together virtually multiple days of the week to figure out what to do with these patients, how to prioritize them. Because when OR time opened up even just a little bit, some of these patients could be prioritized for biopsies, but we had other patients that probably needed greater access to surgical care in that immediate time frame. So really trying to work as collaboratively as possible, upping the ante on those virtual conferences to check in with our radiation and medical oncology colleagues to see if they were comfortable moving forward without a primary biopsy. And yes, we moved forward in that vein at that time. Now, we're back to a more business as usual situation, even as, in my environment right now, our hospital is currently filling with COVID patients again. So even as we're adjusting our OR schedules for this, third wave in Michigan, there will be priority access for this kind of patient on our site.
And did it impact your ability to counsel patients as well? As far as, so a patient like this, where you're, if at least considering if you went down the surgical route, a laryngopharyngectomy, or at least a extended laryngectomy and partial pharyngectomy with reconstruction, how would you counsel that patient with regards to including their family? Now it may be a bit more business as usual, but in the instance of the infection rates going up again, how did you adjust?
Absolutely. So it's in that moment we started using a lot, again, more virtual technologies and care, whether that meant for this patient who at this moment was probably sitting by himself in our clinic without presence of family, hopping on FaceTime or, or phone call if need be, if that's what the patient's, phone allows, but hopping on FaceTime with the family to start going over the options, allow them to hear the whole of the visit whenever possible. That was a little bit different for sure. And then really transitioning, since some of these referrals were still coming in and some of this care would start virtually as well. So many of us had started the telemedicine journey prior to COVID, but even now we have patients who present to us from the referring doctors. We start with a video visit. We've collected all of their data, getting things reviewed here, but can start the conversation with the patient and their family in the comfort of their home, and often are meeting them in a preoperative visit either the day before or, during the height of the pandemic, we were often meeting people in pre-op holding and just bringing them in early to do double checks and whatnot. Even the consenting process has really changed. We do a lot of consenting now virtually, both for whether it's surgical care, initiation of radiation, or even our clinical trials enrollment has really changed. And that's actually been one of the things that has been incredible with all of this angst and difficulty and challenge. The virtual consent process for clinical trials has really changed how we're doing things. And that is one thing that is something that was a great bonus out of this experience.
Very good. Well, while we're calling up the first audience response question, Lisa, could you comment a little bit on how you've approached this as a speech language pathologist? So some of your education sessions, and then in instances where you're actually having to do formal swallowing assessments and swallowing therapy in person, are you testing these people ahead of time? How have you adapted, at least for this particular case scenario, to somebody like this, so somebody with an advanced either hypopharynx or larynx cancer, and working with them, pre-treatment?
Sure. So that's a great question. And we typically were not testing patients beforehand, but we were wearing full PPE. So the N95 masks always, and the associated pressure wounds with that. But certainly we were, at high risk because of airway exposure. We're doing endoscopies if needed, managing any tracheostomy tubes that were associated with airway dysfunction for these patients. So we really capitalized on using telehealth when possible, which actually created an opening for us to really manage our patients at a more close level, because now it was just accessible. We could call patients in the comfort of their home. We could manage them and see how they were doing. But if a patient like this with a piriform sinus hypopharyngeal cancer went on to get a laryngectomy, we really had to shift our practices for managing our laryngectomy patients, whether that's getting them very comfortable with using the electrolarynx, or if they were TEP users, making them independent with managing TEP leakage at home, whether that's with a cotton-tipped applicator, shipping insert plugs to their house, or even getting them comfortable with doing a patient-changeable prosthesis. So from a swallowing standpoint, we used a lot of telehealth and also used telehealth to help manage any TEPs if they were post-laryngectomy.
All right, well, excellent. I can't see the question up on the screen. Christina, if you're able to let us know if it's actually gone up and through. If it is not, then we may end up just proceeding without it. I'll just pause for a minute here. All right, we'll just pause a couple more, about 15 seconds to get any selected choices. It may be that everybody's actually enjoying their lunch. That's the beauty of the virtual session here, is you can do it at any time. All right. And then we can go to the next slide then. So then just bringing us back to our multidisciplinary collaborations. And as I mentioned, many of us have gone through and converted to virtual tumor boards. Is anyone on the panel doing true multidisciplinary clinics anymore?
Yeah, we still are at Sunnybrook at the University of Toronto.
Okay.
Yeah,
Did
we
that
just
ever-
restarted ours.
I'm sorry, Kelly, I didn't mean to interrupt.
No, that's okay. I didn't mean to talk over you either. We actually just restarted ours in the last like 2 weeks.
Tony, did you guys do it through the entire pandemic, or was there a period of time where you put it on hold?
Yeah, it's a great question. Our clinic structure is such that we have several surgeons, several radiation oncologists in the same clinic almost always. During the peak of the first wave, when things really slowed down, we didn't want to co-infect each other. We didn't want to be exposed to each other in case someone got sick. We would have other members of the team available. So at that time, we brought it down to one surgeon and one rad onc at any given intake clinic. And we converted all of our follow-up clinics to virtual initially, unless there was something really urgent. We've since gone back from that. We're all back in the clinic. We're all double vaccinated. We're all wearing appropriate PPE. And so now we have multiple surgeons and radiation oncologists available in the clinic at all times. And we're all in the same space sharing those same patients. It creates, there is something special about that clinic, right? That ability to crosstalk or ask someone to come in for a second opinion on something. Often it's a radiation oncologist who just wants a surgeon to do an extra ultrasound or have a feel of a neck or look at this scope with me. And I think it really does add a lot of value. So, I really hope we do get back to it, but it wasn't really evil.
Yeah, I think Tone brings up an excellent point. We've lost that. There is that instant communication that comes with the ability to interact with each other as opposed to virtually, because there's so fundamentally some lag. We stopped, but we are in the process of actually creating clinic space such that we can sort of mimic exactly what you have in Toronto, Tony, where we can all physically be very close to each other. We didn't even have that before. If anything, the experience that we went through taught us that not having that ability to come together, whereas in the past we all met, several members physically came to a different location. We weren't our clinics were not juxtaposed to each other. It's taught us the importance of that, and now we're actually building clinic space such that the surgeons and rad onc and even med onc and speech pathology will all be in the same physical clinic space together. So that's been a plus for us.
At UCSD, we are all physically co-located in the same clinic space. So that includes head and neck surgery, rad onc, med onc, SLP, our dietitians, even our survivorship NP. So we've always been able to maintain to some degree the ability to have that crosstalk. And even when we were doing more of the virtual visits, oftentimes what many of us did is we would conduct those visits down in the clinic space so that we could be in one of our own exam rooms, but with a phone or an iPad doing these visits. And then if we needed to, we could still, grab one of our colleagues, bring them in, et cetera. Obviously not the perfect setup, but it worked given the circumstances.
I think just building on this, how would you guys manage this patient? So it's a T4A, N2B, M0 squamous cell of the hypopharynx. And so I think the majority of people, at least pre-COVID, would consider upfront surgery with subsequent adjuvant therapy based on the pathologic findings. How are you guys doing this now? Would you treat it by the normal standard of care? Were there any times during the pandemic where you would have said, you know what, surgery is not an option given our current OR availability, we're going to go down the route of non-surgical therapy? Well, maybe we'll start with you, Tina, and then get Dr. Quon's input, and then go back to our surgical group and speech team.
Yeah, so I think the first question really would be, is surgery the best route here, or should a concurrent chemoradiation approach be taken? I would say that either of those would be very reasonable, and then given the circumstances at each institution would dictate that path. I can tell you the question of induction is not one to be used to sort of buy time to get to the OR or other paths. The reason I mention that is, and this may come up in other cases, but with induction chemotherapy, let's just take out the questions about whether or not there's utility in using it. The reality is we're now talking about giving someone extremely cytotoxic therapy that's fairly myelosuppressive. I'm not going to be giving GCSF support. Last thing I want to do is induce a cytokine storm or a hyperinflammatory state, and then they get COVID and have that be even more deleterious. So generally not doing induction to delay any form of curative intent therapy. And then if we're doing concurrent chemorads, there are considerations there in terms of the schedule of cisplatin that would be selected.
All right, well, very good. Harry.
Yeah, I mean, we never really transitioned to non-surgical management in situations where we have extralaryngeal spread tumors. We try to prioritize as best as possible sort of the right oncologic decision. But we certainly entertain the idea of moving towards non-surgical management where, let's say for an oropharynx, especially the HPV oropharynx, where there was reasonable equipoise, we probably favored more non-surgical management in that situation.
Okay. So Tony and Kelly, so if this patient's going down a route of surgery, and it would typically be one where you would do a free flap reconstruction, were you guys using one team, two teams? Did that change at all during the pandemic?
I'll let Kelly go first. Because we had, Kelly, you're on mute, but we had a very unique setup, which I'll share with you. But Kelly, you go ahead.
Sure. So we were able to get most patients like this into the operating room in a fairly facile situation, even when we were largely shut down. These patients were prioritized. In terms of the team members, we did try to limit them. At first, it certainly was for safety reasons. We weren't sure about, I mean, all the things we talked about earlier this morning about, we just didn't really know much about this this virus, and the information coming out of China was terrifying in many cases. So, and we also had the PPE issues. So it was not just to keep ourselves safe. We had to conserve, so you couldn't necessarily have two full teams. You know, we do have two fellows, and we were able to, it was a time of year when our fellows are really up to speed in terms, it was almost like operating with it really was like operating with a faculty member partner. So while we might not have had two formal teams all the time initially, we still were able to move these cases along expeditiously. And we did try to limit the number of people in those ORs. It also helped that our institution, right or wrong, limited medical students, limited any other kind of observers, et cetera, to basically bringing those down to zero in order to keep our teams as safe as possible and our learners as safe as possible.
All right, and Tony?
Yeah, I'll say, so we had a slightly different approach. You know, our OR resource was so compressed, and our wait list became one wait list for all the surgeons. We had one wait list. It was one intake, one output. And so what we did that was unique, I have two more senior partners that are fantastic surgeons, Kevin Higgins and Danny Anapakitis. And so what we did is we actually triple teamed each case. And the reason we did that was actually because we found it very hard to do a 12-hour case with the PPE on for the whole time, and to teach and to have the fellow there and so on. So we broke down a case like that would be broken down into three components. One person would ablate and get the margins. One person would harvest and maybe assist with the other person on the inset. And then the last person would do the micro. And it kind of just broke down the day. And it also gave you a relief. And especially during those first few months when you were still getting used to having an N95 for such a long time. I certainly had damage to the nasal skin from the length of time I had to keep that mask on. So we all appreciated the breaks.
Can I ask one more thing in there? Because Tony, I think you bring up a really important thing. This was a really fabulously collaborative time because of that. Everybody did collapse their surgical lists into one, and that helped a lot. I wish we'd thought of that idea of giving each other more relief. And as soon as our PPE levels came up and testing really came up to speed, we were able to increase certainly the number of teams that we were working with. But the other thing that I just want to mention is that, access to OR, some of those lists have been merged with lists across all of our cancer surgeons. And so what was really cool about how we managed it, and I imagine it happened elsewhere as well, is that we have surgeon leaders in our OR leadership structure. There's myself, I have a urologist who's our medical director, and we work with the anesthesia medical directors. And we had actually like a cabinet of other surgeons from all the different cancer and honestly other really urgent, time-sensitive life and limb serving surgeons to serve as the eyes on the list and to say, how the paper that you showed that was Dr. Toff's work is fantastic for what we were doing in our discipline, but how do you then prioritize against all these other patients that really need us and that are stacking up? And so we engaged in really daily work on that to make sure that we weren't inadvertently scooting somebody up who was a little bit less urgent and could wait reasonably a week or even 2 weeks. That way we could get someone who was more, had more pressing oncologic needs into the operating room more quickly. So it was a really shared resource and a shared method.
Yeah, I think that's a great point. We always think a flap take back is quite urgent, but when you're in a level 1 trauma center, there are other things that may take priority. Well, just in the interest of time, Lisa, if you could just give a real brief statement on your speech rehab for these patients. Are these people that I think you mentioned this somewhat before, but leaning more on the electrolarynx rather than the TEP for now, just for both logistical and safety reasons?
Absolutely. So if patients are going to be getting a laryngopharyngectomy, absolutely getting them an electrolarynx, getting them proficient, and in the time that COVID was really up and running, using that as their main form of communication. And now that things have started to taper down, and reintroducing the TEP. And for patients that are going to undergo definitive chemoradiation therapy rather than surgical intervention, it's really important to kind of take into account the subsite. Hypopharyngeal cancers are there already 70% of these patients are going to be feeding tube dependent in the early acute phase. And when we're giving high toxicity from the treatments, we really need to think about the dysfunctional larynx and pharynx in the long term, and lower cranial neuropathies, and how they may need a functional laryngectomy in the long run to preserve their function.
Absolutely. And I think the sequelae we're going to see from this pandemic, I think it was alluded to earlier in this morning's session, and we're going to be seeing this play out in the years to come, both people presenting later, treatments being altered or delayed, and whether it's cancer cure or functional debilitation, it's going to obviously be things that we're having to help people work through for years to come. So just in the interest of time, let's move into our next case and last case here. Tony Eskander is going to take us through this one.
Great, thanks, Mike, and thanks for the invitation. So this is a 41-year-old gentleman who presents to your office after shaving and noticing a right neck mass. He's 41, so he's otherwise healthy, no meds, no allergies. He is a past smoker, a 20-pack year past smoker, but quit when this popped up. And so I'd kind of, we'll go through the imaging and we'll discuss some considerations, but you scan him and you don't really see anything all that obvious. And before you scan him, you examine him and there's nothing really to see or palpate at the tonsil, base of tongue. Your fiber optic endoscopy is entirely negative, with the exception of this right level 2-3 neck mass that is certainly palpable and mobile and with no overlying skin changes. And so, I think, so what would most people in the panel do? And let's kind of compare it in the early pandemic period to now. How would you typically diagnose this type of patient? Maybe I'll open it up to Kelly.
Tony, can you repeat that? This is pre-pandemic that you were asking? I'm sorry.
No, like right at the beginning of the pandemic. Yeah. It's March, April of last year.
March, April. So for this patient, you know, it's interesting in this regard, it's a little bit similar to the one we just went through. We'd start with a needle biopsy, see if we could get our HPV status established that way, avoid a DL, and then have a conversation about, you know, given that, you know, this is probably a patient that could go either way from a primary surgery perspective or primary radiation-based perspective, have that conversation about which approach would be the best access for him in that moment.
Perfect. So that's exactly what happened for this patient. They had an FNA. And fortunately, in this case, the FNA was positive for squamous cell carcinoma, at least clinching the diagnosis. And it was diffusely P16 positive. There was no question about it. If we can go to the next slide, you then proceed to order a PET CT. And you could see that on the PET CT there that the right tonsil is lighting up. So you suspect that this patient has an early tonsil cancer, probably a T1, T2, N1, M0, P16 positive of the right tonsil. That's kind of where you're at now. And so this leads to a number of questions, right? You know, I think I'll let Mike kind of ask those questions, but for me, the questions are, what if the P16 status wasn't so clear on the FNA? You know, on an FNA, you can't always get the P16 status. It's only if it's, you know, diffusely positive. And in fact, the CAP guidelines suggest that that's really mostly for tissue biopsy, like core biopsy, or on the main specimen, like on a tonsil biopsy, et cetera. So that's one issue. Then the issue is you don't really have a biopsy of that tonsil yet. So those are the two issues that I wanted to discuss at this point, is the tissue diagnosis.
Yeah, I think it's a great point, Tony. And I think especially when you're considering robotics resection, while this one is a somewhat accessible lesion, there are some times where exposure is more challenging, and you may well not know whether they're a great candidate for upfront surgery until you do an exam under anesthesia. And there's still, obviously in the height of the pandemic, that was a much more challenging discussion, and it may become one again. But you know, a lot of it is just to examine the clinic and obviously basing it on the imaging as well. So Lisa, if this patient comes in and they're functioning well, so coming in basically just presented with a neck mass, but otherwise functioning very well, with regards to speech and swallowing assessment and therapy, obviously many would you know, have them assess pre-treatment, whichever route is taken, and then undergo regular swallowing therapy afterwards. You were mentioning you were doing a bit more virtual. Do you start with an in-person evaluation and instruction and then transition it into virtual, or how are you doing that?
Sure. So for this patient that really isn't at a high risk, just given the subsite and the stage, we would typically manage them at the time of COVID completely virtually. It was only if they were at a high risk that we would bring them in for a fluoroscopy just to assess their baseline function. But interestingly enough, dysphagia was one of those services that were not reimbursable by the Center for Medicare or Medicare guidelines up until March 31st of this year. So virtually we were going an entire year of providing dysphagia services that were not reimbursable as of until last week. So that was a bit of a hurdle. Even though we wanted to manage our patients in the safest way, we just were not getting reimbursed for the services provided. Wow.
Well, I'm glad that got corrected, because that's obviously a tremendous service to patients that you're providing. So the questions coming up in our chat, and I think this is where we're hoping to transition to next in our discussion. This came up in the first case, but in a patient like this, Tina, where you could consider upfront non-surgical therapy or surgical therapy, typically with very similar cancer control outcomes, were you guys changing your practice during COVID, or at all swayed based on the current pandemic and your approach to these patients?
I would echo Harry's comment earlier. You know, we were making these decisions based on what was best for the patient. Certainly cancer cases were being prioritized from a surgical perspective. There was a period of time where we were, it was a bit more challenging, but certainly this is somebody that would have likely just gone the concurrent chemo-rads approach. And we would have gone off of the neck node FNA if that was, strongly diffusely positive, and we felt it was HPV, we may not have pushed for a tonsil biopsy. I agree with Tony, it would have been challenging if that was negative, because then we likely would have pursued more of that surgical eval up front and potentially committing folks to trimodality therapy. So there are some nuances there, but a definitive chemo-rads approach would have been appropriate and we would have pursued it.
Okay. And then Harry, similar for you. I know you mentioned it earlier, but then also did it impact your ability to offer clinical trials like de-escalation trials for these patients at Hopkins?
Yeah, I mean, I think it's fair to say that at most institutions, clinical trials as an entity itself was shut down because of a need to stratify in terms of patient encounter. So we certainly didn't have any options for patients from that perspective. To answer that second question first, and we took the same approach. We unfortunately didn't change anything in terms of how we approach these patients from a therapy perspective, except, we were more cognizant of the potential impact that our treatment was having on the lymphocytes and their counts, and running the risk of complications, particularly pneumonias that would then add to the added difficulties in distinguishing this from COVID. And oftentimes when patients did have a little bit of fever, a little bit of cough, we were in this real dilemma of whether or not to evaluate them for COVID and put them through that.
I think with that in mind, so how were you guys addressing that? So say somebody goes down the route of either non-surgical management or they're in adjuvant therapy and they either test positive or you're strongly worried about them based on the screening intake when they come in. Obviously for testing positive, has that changed how you address these patients? I know it was mentioned earlier that early in the pandemic, I think everybody kind of stepped away and really tried to evaluate things a bit more from afar, whereas some institutions now have developed protocols to allow for this therapy to be ongoing in a way that tries to keep both the patient and the healthcare team safe. How have you guys managed that at your institution?
No, absolutely. Early on, we actually had a patient who developed a larynx cancer patient develop a pneumonia who proved to be COVID positive, and we had to stop treatment. For that reason, there was a large interruption in treatment. You made the best with it with various strategies to try to minimize the overall impact on the cancer care. And unfortunately, that patient actually did recur. We've been able to pivot with a variety of different strategies to allow for treatment. It's taken a fair bit of institutional commitment, which I realize is not a generalizable solution. I mean, the solutions are obvious. We've developed one of our treatment rooms that has negative pressure ventilation. And we're doing the same with one of our clinic exam rooms to have negative pressure ventilation capabilities for patients who we do know has COVID. The real challenge is really the asymptomatic patient who may actually have COVID. And then what do you do with that in terms of the environmental risk for both staff and subsequent patients who come into that room?
So at UCSD, we developed policies right out the gate, and we may have had a little bit more lag time to do so. But, for both infusion services as well as radiation services, we started our lab folks here were able to create an in-house assay fairly quickly and get that going. We started testing even in April timeframe. We were testing prior to every cycle of chemotherapy. For folks who are on concurrent chemo rads, they got tested prior to start, a few days prior, and then they were getting tested a few times during treatment as well. If someone was came back positive, but they were asymptomatic, we basically had a conversation with them. It was a whole new risk and benefits consent discussion, right? About proceeding with treatment with a positive active infection. And if they were amenable, because again, we're thinking about what's more likely to cause them harm, COVID or cancer that recurs, we actually treated them. Within the infusion center, private rooms, we had pathways to how to locate these patients so that they were not infecting others, making sure that our staff had the appropriate PPE. Our radiation colleagues, we would also treat at off-peak hours. So we'd move their appointments to later in the day. We took various strategies to minimize that risk as much as possible. And then if people had symptoms, then that was really the question, how long do you delay? And there were potentially some breaks depending on the severity of symptoms present, and possibly for 2 weeks or more. We've learned since that retesting is actually not the preferred strategy to get folks back on treatment, right? Because many of them can still shed low levels of virus and they still turn positive, and then you still don't know what to do with them. So we've gone more to this symptom and time-based approach for discontinuing isolation precautions, but we still were treating even with mild symptoms or asymptomatic. It was really, and the issue there is, as you know, we don't know if they're going to go from mild symptoms to having a severe process develop quickly, and we just hoped for the best in light of the situation.
No, I think it really also brings up the nuance of the symptoms that can develop just naturally during therapy. And, as the director of infusion services there, I'm sure you run into this. We see this at our cancer center as well. So somebody who comes in with like a neutropenic fever or something, so they're not passing the screening questions at the front. And then how have you guys managed those? And they're not always necessarily head and neck cancer patients, but I think it's pertinent because it's, these patients, whether it's a cough or otherwise, a lot of these there's going to be a lot of overlap of these symptoms. Are these all getting tested, or presumptively just, tested, but then that day treating them as a person under investigation as far as precautions? How are you guys managing that?
Yeah, I mean, for head and neck, it's a challenge, right? Everyone loses their taste during radiation, so that automatically triggers a positive screen. If you have lung cancer, you're automatically going to trigger a screen because you have a cough. I think, the questions that were being posed, we were looking at acuity to determine whether this was somebody who has a chronic cough because they're a COPD or comes in on 3 liters of oxygen. We know they're going to cough, trying to gauge the acuity. If they tested positive, we had a process in place where their oncologist would be contacted. They would be treated as a PUI. We would determine, again, on the spot, is that someone who needs to be emergently or urgently treated? If it was felt that their delaying their therapy would actually be more detrimental than beneficial, then it would basically be a call to me as medical director, who I would work with our nursing director to figure out how we're going to treat these patients and also make sure we had the resources to do so. But with having the testing in place fairly rapidly, it helped us quite a bit because our patients were complaining, and they still are. I get it. It's not fun. We were getting weekly testing for months, which they finally let go of after we got vaccinated, thankfully. But we had the rigorous screen at the door. If there was any question of PUI, we had a pathway to kind of move them aside to figure out what to do. Do we treat them that day or not? And then we would test them as well at that time. So it was imperfect, but we were trying to be as safe as we could.
All right. Well, in the interest of time, I'll just do a couple more quick discussion points, and then if at the end we have any additional time for questions, we'll field some. So cancer surveillance, how has this changed your approach to that? Are there certain patient populations you absolutely still want to see in the office? Dr. Tang in the prior panel had mentioned the use of cell-free DNA for HPV-related cancer surveillance and its emerging role. So when do you actually feel in an asymptomatic patient that you absolutely would still want to evaluate them and consider a scope in the surveillance context? Or which patient populations do you really feel like at least you can space out the visits less frequently? We could start maybe with Tony.
Yeah, sure. That's a good question. I think all of our patients with, leukoplakia, lichen planus, any of these lesions that you're following closely, very hard for those patients to report that to you, although maybe the Cancer Surveillance Service will change that in the future, a little plug there. So those patients, also the laryngeal cancer patients, I think, those patients really do benefit from a fiber optic examination. Some of them benefit even, quite frankly, psychologically, like they just need that visit. And some of them have insisted to continue to come in, and I've not pushed them back, despite it being an AGMP procedure, et cetera. Those are patients I've prioritized. I think the low risk patients as it relates to recurrence, the T1, T2 tongues with low risk factors, and the early larynx cancers like the T1As and Bs, and even the early T2s, as well as the early stage oropharynx cancers. I personally have been spacing those out with a virtual consult, with a virtual visit, and then spacing out their visits in person a little bit more.
Kelly, similar for you?
Yes, in the interest of time, I would say my practice is evolving very much along the lines that Tony just described as well.
Yeah, I would say, certainly thyroid cancer as well, and it's a little bit outside of the discussion here, but much more of ultrasound and thyroglobulin and a virtual visit. I think it really has changed the way we're going to manage a lot of these, and a lot of these would be followed up with the endocrine team as well regularly.
Yeah, the other thing I would add is that even some of our patients, say in the melanoma practice, or even some of our mucosal patients who have still have relationships with their local otolaryngologist. We've also been creative about, maybe it really is once a year with me, sooner than it would have been once a year pre-COVID, because they are actually going in for a scope exam with the wonderful doctor who's diagnosed them in the first place. So there's a lot more creativity in that system. And I think that's actually been very beneficial for patients in terms of the overall financial burden of their follow-up and their survivorship care.
Well, just in our last few minutes here, I did want to touch briefly on vaccination. And obviously with these, you're worried, one, about the patient's tolerance of the vaccine, but also weighing it about the fact that they're going to do worse if they get COVID and they've either got active cancer or are recently recovering from cancer therapy. But the other part of it is obviously their ability to mount a meaningful immune response if they're amidst therapy. Tina, what are your thoughts on it? We actually have a study that's about to get off the ground here. I'm only peripherally involved in it. One of our cancer center members is running it, where we're looking at patients in active chemotherapy in different types. This is not a head and neck cancer specific one, obviously, and looking at basically antibody titers in these patients, different stages after vaccination, to see who mounts the response, and then obviously following whether or not they're protected from infection. How are you counseling patients amidst active therapy, getting them vaccinated before, or are you doing it on certain time iterations during therapy? I know there are some guidelines and guidance from ASCO, I believe, on this.
Yeah, I will tell you that most of my visits surround discussions about COVID and vaccinations, and less about chemotherapy and all the horrible side effects from the cancer-directed therapy. There's a few things. One is, a lot of times I'm having to advocate and convince patients to get the vaccine. Many are worried about the fact that it was done so quickly. My African-American patients, I'm having to really talk to them about, and other, certain ethnicities and races where there's more fear about and mistrust. The key that and then the other concern too, which was highlighted nicely in the previous talk, is these 3 different vaccines that exist really are apples and oranges comparisons, right? I'm getting asked a lot, which vaccine is most effective? Which one should I get? And I have to explain, we don't know. And number 2, you don't get to choose. It's based on availability. Now, I tend to tell folks not to get their vaccine right around, say, a cycle of bolus cisplatin, because they might not feel well from chemotherapy, and we don't need to complicate matters if they do have a reaction to the vaccine and then they don't want to get more chemo because they're blaming it on that. I also take into account where their counts are and where their nadir might be, just to try to avoid timing right around when they're going to be the most neutropenic or most lymphopenic. But having said that, I mean, the reality is everyone is in such a rush to get vaccinated, and I think it's critical that we do, that none of us are necessarily using any clear-cut, predefined time points for when to do it. It's a case-by-case basis. I have a lot of patients who just message me and say, I've got an appointment for tomorrow. Is it okay to get it? And I'll quickly look to see where they're at in their therapy and just give them the go ahead. In the absence of any concrete data saying you absolutely should wait this long or that, I think the best approach is just common sense, best judgment where they're at, and just advocate, because there are a lot of our patients who are afraid to get the vaccine. And I will let them know, I'll even talk about having gotten it myself, and et cetera, just to kind of push, because while there are many who are motivated, I think there's still a fair number of folks who are worried. But timing, there's no perfect science there. I look at where there might be in their cycle. I don't give it right at the time of chemo, and I try to avoid when I think they're going to be metered in terms of their counts.
Excellent. That's very, very helpful. So just in the interest of time, we'll go ahead and wrap up here. So obviously, as has been recognized, COVID's really impacted our head and neck cancer patients, and it's impacted our ability to care for them and then communicate closely with both them and their families. But that's a huge part of it, is really staying closely engaged with them and communicating to their families during and after treatment, even in the context of visitor restrictions. And our approach to outpatient evaluation and counseling has been modified to some degree, but in many areas, we're starting to get back a little closer to normal. And in reality, for the vast majority of us, the recommended treatment is still going to be the same as what our standard of care would be. Some of the exceptions may be when there are real spikes in infection rates in certain regions, limiting access to surgical care, and also limiting availability of certain clinical trials. And as was mentioned, the importance of COVID vaccination can't be emphasized enough. It's such a key part of getting us through this and getting us past the infection. I did want to thank all of our panelists. Really great and robust discussion. Really honored to have you join me in this, and really appreciate Dr. Dessler, Dr. Nance, and Dr. Nathan for allowing us to be a part of this. Thank you so much.
You're welcome, Dr. Moore. I want to thank you and the entire group. Really an outstanding discussion and an example of how collegial we can all be and how we're all in this together. And you're great doctors, you're great colleagues, and thank you for sharing the time. So to everyone attending the morning session of the meeting, thank you. We'll adjourn for an hour. We'll resume at 1 p.m. Central Time with our next panel. I urge you to visit the COSM exhibits if you have a little time, peruse the rest of our program and tomorrow's program, and then prepare for some outstanding panels this afternoon. Be well, everyone, and see you soon.